Good evening. On behalf of Florida Hospital, thank you for joining us in our latest installment of a distinguished speaker series. I am Dr. Ademola Adewale, an emergency physician at Florida Hospital, and I can tell you that I see firsthand the horrors of opioid abuse. This is a crisis that knows no boundary, no barriers, no socioeconomic status, no demographic, and by gosh, no community is immune to it. If you think it's not a problem in Central Florida, just ask our nurses, our teachers, our social workers, our law enforcement officers, and they will tell you it is a problem. And you may want to ask the grandmothers that are taking care of their grandkids because their loved ones have passed from opioid overdose. Every day in the United States of America, about 115 patients die daily from opioid overdose. This is unacceptable statistics. It's hurtful to hear that every day 115 people, loved ones, die daily from opioid overdose. But what is encouraging, though, is people are taking notice and actions are being taken. 2 days ago, the governor of Florida passed the law, HB 21, basically that regulates and gives doctors guidance as to how much opioid they can prescribe to patients that they see in the hospital or in their caring facility. This is a first step, and I think it's the first of many steps, because we have to address this from where, who's prescribing the medication. So that's a big plus for our governor for passing that law. Now, tonight, Dr. Lipi Roy will educate us, enlighten us on things she has learned over the years. She's a board-certified addiction medicine physician. She's a clinical assistant professor of medicine at NYU Department of Population Health. She currently serves as a medical director of a New York City Addiction Treatment Center. And also, among all the hats she wears, she is the former chief of addiction medicine for New York City jail system, which is the second largest jail system in the country. Dr. Roy is also a primary care doctor to Boston vulnerable homeless population, among whom the leading cause of death was drug overdose. She served as an attending physician at Mass General Hospital and has been a faculty member at Harvard Medical School. As a longtime advocate for public service, she served the underserved in Nicaragua, in India, New Orleans during Hurricane Katrina, and also provides support during the Boston Marathon bombing. She is currently a Forbes contributor, has appeared on CNN, on Charlie Rose. She has published several publications on Huffington Post, Stat News, and she's also been featured in Boston Globe and the Wall Street Journal and Oprah.com. We are honored this evening that she's joining us and sharing her insight, and I would like you to please help me welcome Dr. Lipi Roy.
I really got to shorten that damn bio. I'm so sorry. You guys had to deal with all that. When I first got the invitation to come down here, I reached out to my former med school classmate, Brian, who's a Floridian, born and raised, and he's back here practicing in Florida. And I said, hey, Brian, I'm so excited about this lecture. I'm coming to Orlando from cold, chilly New York. And, it's such a serious topic, but I want to say things that are kind of fun and lighthearted. And he said, all right, Lipi, well, remember, it's Orlando. They've got Disney. They're tired of hearing happy jokes, And I said, okay, so then I shouldn't make a joke about, what's Peter Pan's favorite restaurant? Wendy's. Okay. And he said, yeah, no, Lipi, don't say that. That's just kind of lame. I'm like, okay. And I said, but Orlando also has a basketball team. And he's like, yeah, Orlando tragic. I'm like, oh. And I said, so, okay, 'cause I'm a hockey fan. I don't know anything about the NBA. And I said, so I shouldn't make a joke about how, what do you call an Orlando Magic player with a championship ring? A thief? No. And Brian said, no, Lippy, definitely don't say that. I'm like, okay. Truth be told, so I in all pure self-deprecation, I just flew down here from New York, managed to fly down with a lot of logistical changes and issues because of the bad snowstorm. And look, the running joke in New York City, one of many, is that, cars aren't the only thing that are useless in New York City. Apparently, so are good manners. So, but in all seriousness, ladies and gentlemen, I am so pleased to be here. And if over the next 45 minutes or so, if I do my job right, you'll see that I'm deeply passionate about this topic. And before I move on, let me just say that I'm deeply grateful to Stephen Sukow from Florida Hospital for the generous invitation to speak to all of you. And thank you, each and every one of you, for taking time out of your busy schedules to come and participate in this topic. So let me introduce you to somebody who's very important to me. This is Brian, different from my classmate Brian. This is one of my former patients. I first met Brian when I was a primary care doctor to Boston's homeless population. Frustrated, depressed, and struggling with severe neck, shoulder, and back pain, Brian just had it. He said, Dr. Roy, I can't take it anymore. I just need help. In addition to his medical and mental health issues, Brian had also just lost his job and he lost custody of his son, which drove him deeper into depression. Ashamed but desperate, he started to use heroin to relieve his pain and suffering, and he just couldn't stop. Sadly, Brian's story is not unique. It turns out that the leading cause of death amongst my patients in Boston at the time was drug overdose, as you heard in the introduction. When that data came out in 2013 by my colleague Travis, who's also a primary care doctor, but mostly a researcher, when Travis looked at mortality data amongst Boston's homeless population over a 5-year period, the data showed that the leading cause of death was drug overdose. And that information completely transformed the way that me and my colleagues provided care. And I'll talk a little bit more about that. So just a quick outline in terms of some of the topics that I'll be touching on, the epidemiology and neurobiology of addiction, how we treat it, medications, myths about methadone, psychosocial therapies, naloxone, stigma, harm reduction, and some really good resources. So I think we've all seen these pictures, right? We've seen this, Heath Ledger, I think he was only 27, Philip Seymour Hoffman. What's interesting about this brilliant Oscar-winning actor is that he was in recovery for 20 years. And then in 2014, something happened, a few different things happened, and he relapsed. And then he was one day found alone in his New York City apartment, surrounded by drug paraphernalia, not just heroin, but multiple drugs. Janis Joplin, again, this is not addiction, it's not new. Judy Garland, and then more recently, Tom Petty. He actually died last year, but the cause of drug overdose, that just came out recently, and that's where I wrote a piece in Stat News about his death. But as we all know, all too well, addiction doesn't just impact the rich and the famous, right? We've all seen these headlines. Overdose, drug killer next door. Mother of Capitol Hill overdose victim. There's no way to describe this grief. And then we started to see signs of some intervention. New England governors converged to address the opioid epidemic. And then right here in Florida, opioid informational sessions being held. And then on the federal level, Obama's administration came up with CARA. And then more recently, current administration calling it a public health emergency. So we all now know that this is a nationwide epidemic. You've probably seen the CDC data. So this is what the country looked like in 1999. The red patches indicating overdose deaths per 100,000. And then a mere 15 years later, this is the landscape of the nation. Red indicating overdose deaths. But I'm sad to tell you, ladies and gentlemen, that that's way back in 2014. It's now 2018, and I guarantee you, oh, sorry about that. I guarantee you half this, 70% of this map will be red. Because not only have the deaths been declining, it's not even plateauing, it's going up. That's why it's so critical that we all come together to really talk about this. And overdose deaths not only exceed traffic accidents, it now exceeds gun homicides. So I know we hear a lot about deaths, right? That makes the headlines, and justifiably, right? I get it. The people that are dying, that should be the acute problem, right? That we should be paying attention to. But I want to make sure that you know that for every overdose death, this is the number of people that are being treated and admitted to the hospital. These are the number in the emergency departments. This is the number that are misusing, that are dependent. But look at this foundation of the pyramid. These are people who are using, maybe recreationally. They haven't overdosed and died yet. So how did we get here? How many people have heard of Purdue Pharmaceuticals? So in 1990s, they created a medication called OxyContin. They funded over 20,000 pain-related educational programs. And they also provided financial backing to the American Pain Society, which came up with the Pain is the Fifth Vital Sign campaign. But they also funded the Joint Commission. And that's an organization that really helps train people like me, young doctors, trainees. What's key is that in 2007, Purdue was fined over $600 million for deliberately misregulating the government, doctors, and patients and regulators about OxyContin's addictive qualities. But you know, it's also a question, an issue of good intentions gone wrong. Doctors were pressured to treat this pain as the fifth vital sign. Incidentally, there has been no crisis in pain. Pain levels have remained the same. The way that we manage it suddenly changed in the mid-90s. And doctors were told two key points. Opioids aren't addictive, and they were told that treating opioids, treating pain, chronic pain, long-term with opioids was evidence-based. Both points patently false. Now, there were some bad apples, for sure. There were some doctors that misprescribed, took advantage of financial incentives, but they were really the minority. The vast majority of doctors learn very little about pain management in medical school, and even far less on addiction during medical school and training, residency training, mostly none. And by the way, everything that I'm telling you today has been on-the-job training, learning. And I went to good institutions. It's just a reflection of how little doctors are really learning about it, but things are changing. So yeah, I just spent some time talking about this pharmaceutical company, but let me be very clear on what the true causes of addiction are. So, you know, we always, when we think of addiction, we tend to think of substances, right? We think of tobacco and alcohol and heroin, but there's also other activities and behaviors that are addictive, right? Gambling, pornography, video games, smartphones. We're all addicted now, it seems like, right, on smartphones. Food, bread, Oprah. But who's not addicted? Who doesn't love bread, right? Coffee. How many people already had 1, if not 5 cups of coffee today, right? And then, of course, my vice are sweets. And even I'm Canadian from Toronto, but that's not why I put up donuts. I could have put up a chocolate cake. But I'm here to urge you, to really encourage you to realize that it's actually not these individual substances or behaviors that are the cause. They are the consequence of addiction. Actually, it's people who experience divorce, loss of a job, their child dying, their spouse getting diagnosed with leukemia, sexual abuse, physical, emotional, hurricanes, tornadoes, 17 of your classmates dying in high school, suddenly from violence. And all of these traumatic experiences lead to complex set of emotions: isolation, grief, anger, frustration, shame, guilt. We all experience some type of stressful experience, right? Stressful event, tragedy, trauma. And then if we don't have a support system, the genetic makeup, medications, healthcare, if we don't have those things in place, any one of these things can develop in any one of us. So I want to make sure that we're all clear on the definition of addiction, which is a chronic medical disease, a relapsing and remitting disease of the brain where relapse is expected. And despite the harmful consequences to the person using or to the people around him or her. It is not a sign of moral weakness or failure. And while the initial decision to use may be voluntary, the truth is that the changes that are happening in the brain impair the person's ability to control their drug use. We get bombarded in medicine and I'm sure in many fields on the various, there's just so much things that we have to remember. It's important to have acronyms. So I like to think of the 4 C's of addiction. Impaired control over drug use, compulsive use, continued use despite harm, and then cravings. Really keep that in mind when you think of addiction. That is the #1 symptom in addiction, intense cravings. So when somebody's having, say a heart attack, one of the primary symptoms is chest pain. Well, in addiction, the primary symptom is cravings. So addiction has been really well studied for a very long time. I'd like to focus your attention on 3 parts of the brain that play a role when it comes to addiction. One is the basal ganglia. This part of the brain is involved in motivation, reward, pleasure. It releases dopamine, the neurotransmitter for pleasure. Then there's the the amygdala. This is the fight or flight part. If you see a bear, it's your body, it's that part of the brain that controls your response, as well as anxiety, irritability. Then the third part of the brain that's really key is the prefrontal cortex. That's the front part of the brain that's really involved in these executive decisions. So think about it. When you woke up this morning, you went to work, but before you did that, you probably shut off your alarm clock, you figured out what to wear, you may put on a pot of coffee, you had breakfast, you arranged for lunch, you might have checked your phone, and you're thinking, yeah, Lipi, that's just common sense, I do that all the time. But your brain, specifically your prefrontal cortex, did all those decisions for you in split seconds. Now imagine doing all these complex decisions, making all these decisions throughout the day, but that your brain being hijacked by certain substances, especially ones that bind to your brain. So the first cycle of addiction would be when a person consumes an intoxicating substance and gets the rewarding effects. So that could be maybe 1 or 2 glasses of wine, a piece of chocolate cake, dopamine's being released. You enjoy it, it's pleasurable. But then imagine a person's experiencing the negative emotional state when you're no longer using. Those are signs of withdrawal. Irritability, anxiety, it's part of withdrawal. And then individual seeks that substance even after a period of abstinence. Think of Philip Seymour Hoffman. He was in recovery for 20 years. Something happened, relapse. And again, as I said before, relapse is expected. It's not a sign of failure, and we'll talk more about that. In fact, I talk about it now. So, surprise. So it's interesting, so diabetes, up to 50% relapse rate. High blood pressure and asthma, 70%. In comparison, addiction's just kind of in the middle there. And yet people are always talking about, oh, he's relapsing in addiction. But my diabetic patients are relapsing, and my patients with asthma and high blood pressure are too. It makes the point that relapse rates for addiction resemble those of other chronic diseases, but we don't really talk about it that way, do we? So how do you treat opioid addiction? There's really 2 tiers. There's medications, pharmacotherapy, and psychosocial interventions. I'll focus some of the time on these 2 because most of the data exists for these 2. So pharmacotherapies are medications for addiction treatment. I know you've probably read in the newspapers and magazines, online, medication-assisted treatment. Let's be really clear. These medications I'm going to talk about, they're not assisting anything. Just like metformin and insulin, they're not assisting people with diabetes. They are treating people with diabetes. These are medications for addiction treatment. So let me talk a little bit about methadone. What is it? It's a medication that's similar to morphine. It's binding the same receptor. It's used in maintenance programs to treat people addicted to heroin or other opioids. It's also used to treat chronic pain. And how does it work? So it binds to the opioid receptor. And as you can see by this map here, this graph, it's a full agonist, all right? But unlike heroin, so you might think, well, it's binding the same receptor as heroin. It's like heroin. But the difference is the pharmacodynamics and kinetics. Heroin's action onset is like this, within 1-2 minutes, and then comes crashing back down. That's why people use it to get a high right away. Whereas methadone, it takes hours, if not days, to build up, and then it stays in your system for days. That's why it's effective as a medication in terms of reducing withdrawal symptoms and cravings. Make no mistake, it allows patients to engage in recovery and treatment efforts. It is a life-saving medication. I want to make sure that we're very clear on detoxification, detox, and maintenance. Detox is the definition is that a person is weaned slowly off their addiction or dependence on opioids using methadone. You can also use buprenorphine. But relapse rates from detox alone are over 90%. Detox is not treatment. As opposed to maintenance, being on a medication long term, it's very clear, prevents withdrawal, reduces cravings, and it blocks the effect of illicit opioids. It's the path to recovery. Again, everything I'm telling you, on-the-job training, I didn't learn any of this before, all right? I learned that methadone maintenance, the public health impact is pretty immense. Reduces risk of HIV 6-fold, reduces hepatitis C and B transmission, people go back to work, reduces crime, reduces illicit opiate use up to 70%, increases length of life, and then this is the real key message here, reduces opioid overdose deaths by up to 80%. People live. I'm sure some of you have heard some myths, though, about methadone. I certainly have. I hear them every day. One of them is, well, methadone substitutes one addiction for another. How many people have heard that? I hear this all the time. So this is what we're all going to do collectively. The next time we hear this, we're going to kindly, gently, but firmly and respectfully correct the person who says that by saying that methadone, in fact, is a medication used to treat people with opioid use disorder or opioid use issues. It reduces cravings and withdrawal, restores balance to the brain. It allows recovery. Another myth that I hear is that methadone will get you high. How many people have seen people standing outside a methadone treatment program? You know, they're kind of like this. Let me tell you, it's not the methadone that's doing that. People that go to methadone treatment programs are often taking other medications. They're on psychiatric meds, which are very sedating. Many of them are also on benzos, either prescribed or not. But it's benzos that kind of cause that effect. It's not the methadone. Now, methadone in conjunction with all these other medications, drugs, can cause sedating effects. But if the methadone is being properly prescribed and people are going to see their doctors regularly, it's extremely safe and effective. But when you hear people say, oh, methadone's going to get you high, make sure you let them know that an individual, when they first start treatment, they may feel a little lightheaded and sleepy, but that's for the first few days. Then the body develops tolerance and they begin to feel normal. A little bit about buprenorphine, also known as Suboxone. So it's also a medication that binds the same opioid receptor as morphine, as methadone, and it's used to treat people with opioid addiction. It can also reduce pain. It's unlike methadone, it's not a full agonist, it's a partial agonist. But think of it as a magnet. Buprenorphine is such a strong magnet, it'll bind the receptor, the opioid receptor, and bump off whatever was already bound there, okay? But it'll stay bound and it'll still have effects at that receptor, but not enough to cause euphoria. It still allows patients to engage in treatment and recovery. And because it's only a partial agonist, the risk of overdose is very low. Make no mistake, buprenorphine, like methadone, is a life-saving medication. Psychosocial therapy is very, very important. We've known about this for a long time. It helps people engage in substance use treatment, provides incentives for them to remain abstinent, modifies their attitudes, behaviors, and increases their skills to be able to handle stressful situations. And there's many different types. I'm just listing a few of them: CBT, motivational enhancement, adolescent family behaviors, 12 steps. There's several, but these are just some of them, and they're really, really important to be used sometimes in conjunction with medications. So this is where I really want to make sure that we all can work together in terms of having practical strategies to combat this. So let me list a few that I think are really important. One is, and this is probably number one, which is why I listed first, reducing the stigma that's associated with addiction. What's stigma? It's really any type of attribute, behavior, or activity that's socially discrediting. So why is this important? Of the 23 million Americans with substance use disorder, only 10% access treatment. Stigma is a major barrier to care. According to the World Health Organization, drug addiction is the #1 most stigmatized social problem. Not medical problem, not health problem, social problem. More than incarceration and poverty and homelessness. More than mental illness, more than alcohol. Drug addiction. So I'm going to offer to you a very simple but effective way to reduce stigma, and that's by altering our language. So studies show that when we use punitive, tough, stigmatizing language like substance abuser, drug abuse, war on drugs, your urine is dirty, you're an addict, junkie, lush, cokehead, and plethora of other words. Studies show, and by the way, I was trained to say, admit a patient comes to the ER or comes to my clinic, oh, he's here for substance abuse. Oh yeah, he's got substance abuse, she's got substance abuse, he's an alcohol abuser. And I don't know about you, but I do know personally that sometimes it's harder to unlearn something than to learn it. It's taken me a long time, but I recognize how damaging these types of phrases are. And studies show that when we use this type of language, patients are less likely to seek help, and they're more likely to perceive discrimination. And healthcare professionals, when they use language like this and when they hear this, they have less regard with patients who have addiction, and they describe them as being less motivated, angry, manipulative. And they spend less time in clinic with them. All of this adds up to suboptimal care. In contrast, let's start using language that's less stigmatizing, that's less judgmental, like a person with substance use issues, a person with substance use disorder. Your urine is positive for opioids. In my patients who come in with a blood sugar of 800, I don't say, oh, your urine is dirty with sugar. I also don't say, we don't say that. I also don't say, well, how did their blood sugar get to 800? When I ask them, oh, what'd you eat today? And they, I don't say, oh, well, you've been abusing a case of Dunkin' Donuts, In that case, I abused Ben and Jerry's last night, right? But we use this language with people with addiction. Studies show we've got good data. By the way, I have references for every single thing that I'm saying here. There's references. When we use language like this, patients feel less judged. They feel more respected. They are more likely to seek care. And that's what we're trying to do. Another really key strategy in terms of combating opioid addiction is naloxone. How many people have heard of naloxone or Narcan? Of course. And we gotta make sure it's creative and pervasive. So, Every time a person gets a prescription for an opioid, and by the way, opioids aren't really the bad guy here. Opioids, for many patients with chronic pain, opioids are still clinically indicated. So, and that's fine. So for that patient who gets that prescription for Percocet, oxycodone, Dilaudid, morphine, make sure that they are also getting Narcan or naloxone. So that's at the individual level. And then at the community level, how many people know about AEDs, defibrillators? They're everywhere, right? They're in airports, they're in schools. We need to do the same thing with naloxone. And in fact, in Rhode Island, they've created something called the Nalox Box. We need to make sure naloxone is widely accessible. But if we're going to do that, we got to make sure that naloxone training is widespread in the community. A third strategy is making sure we reduce this egregious treatment gap by making sure people get access to medications, evidence-based treatment. We know that MAT, like methadone, buprenorphine, naltrexone, they decrease relapse, they decrease death, they decrease healthcare and criminal justice costs. They allow recovery, and yet only 20% of opioid use disorder patients receive evidence-based treatment. But let me share with you a successful pilot from a public health department. The New York City Department of Health and Mental Hygiene, they created a pilot in 2017 where they provided training and funding for a year and essentially enabled 12 primary care clinics to offer buprenorphine. And what resulted is 25 new buprenorphine prescribers with the capacity to treat it's now actually over 750 patients. And I don't see that as a number. I see that as really almost 1,000 lives saved. It's doable. It really is. Another key strategy in treating people with opioid addiction is the concept of harm reduction. Again, I never learned any of this in medical school and residency training, meeting people where they're at. So what's harm reduction? It's essentially a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. And it's a social justice movement that's built on a belief in and a respect for people who use drugs. And it's a spectrum, starting with safer use, to managed use, to abstinence. The first goal is not abstinence. The first goal is to make an environment safe for the person who's using. And really the principle is meet the patient or meet the client where they're at. I like this harm reduction wheel. Can you think of some examples of a harm reduction? Anyone? I already mentioned one in my previous slide. Yes, I heard somebody say needle exchange. What else? What did I just talk about on my last slide? Naloxone, yeah. And there's so many others. Needle exchange. Naloxone, condoms, prevent STIs, STDs, care coordination, groups and support services, health services. So let me share an example with you. In New York City, the Corner Project in Washington Heights, they do great work. They really help reduce stigma by offering a lot of these really wonderful services to the men and women there. And then there's also the program called Insight in Vancouver. How many people have heard of Insight? So they are actually this continent's first safe injection facility. And they offer a continuum of care: addiction, mental health, HIV/AIDS, about 800 visits a day, almost 300 visits per year. But you can only imagine the pushback and resistance that they faced when they first started. They opened in 2003, but boy, oh boy, these are some of the headlines when they first came out. Tons of controversy, including, oh, injection sites are not the answer. It's a mobile crack house. Look at this quote: attracts drug addicts, homelessness, crime, and litter. I don't know where the litter comes from, but apparently they're tossing litter everywhere. But look at this. This is a quote I also read by a newspaper clipping. We don't give drinks to alcoholics. We don't give places for rapists or rape people. So why are we giving places for drugs? Tremendous pushback and really outrage. And yet, let me show you something. Since 2003, the data has been unequivocal. Decrease in IV drug use, decrease in overdose deaths by 35%, decrease in HIV Hep C, increased connection to treatment, no increase in drug-related crime, no fatalities. And by the way, there are harm reduction, safe injection or safe consumption sites in other parts of the world. All show the same data. Just something to think about. And actually, while I remain extremely optimistic as a human being, I'm really not in this one area in the United States, and that has changed. We're going to be seeing something like this soon, I think San Francisco, Philadelphia, Boston, probably New York. So, and again, if you told me 10 years ago, 5 years ago, that, oh, Lipi, you know, let's create a place where we can give people needles so they can inject heroin, I'd say you were crazy, crazy. But I'm also a doctor, and my goal, my professional obligation and responsibility is, what's the first one? It's primum non nocere, which means first do no harm, and then it's really to save lives and improve the quality of life. I cannot ignore data, and data that's been reproduced time and time again. So, and these are just 4, there's really so many other strategies. There's also increasing psychosocial support. As you heard earlier, I was a doctor to a homeless population, you know, so let's make sure people get housing, education, employment. What about integrating primary care with substance use and mental health? As well, pain management. Again, we need to make sure we train doctors and nurses and surgeons and the wider community about how to really properly address pain. And really, we need a lot of criminal justice reform. There's a lot of different areas where we can really make a difference. And this is just a bigger, more comprehensive, multi-system approach. Educators, health systems, communities, the government, researchers, healthcare professionals, and then at the very individual level, we all need to work together on this. And I'm very optimistic that we're going to see big changes. So what happened to my patient, Brian? So the first thing I said to Brian was, thank you for sharing your story. We're going to work together to get you the care that you need and deserve. I connected him to psychiatry, to orthopedic surgery, to case management, to help with clothing, housing. I also started him on buprenorphine for his opioid use, his opioid addiction. In time, Brian started to feel better. He started feeling better emotionally, physically, mentally, spiritually. Today, Brian has an apartment. He has a relationship with his son. He is in recovery. In total, Brian's life now has a sense of purpose. What's also interesting is that Refinery 29, one of their producers created a documentary short where Brian's story is featured, and I'm there along with him sharing his story. A real privilege, and you're able to see this for free online. So it's just a great success story, Brian. So this is just a short list of excellent resources. I also encourage all of you to check out PCSS, PCSS. Excellent online modules, webinars, all free and just really informative. And then there's lots of movies, TV, film, books, CNN, Lisa Ling, HBO. I highly encourage you all to read Chasing the Scream by Johan Hari and Dreamland by Sam Quinones. Also, from Plagues of Prisons by Ernest Drucker. And last but not least, thank you so much. Feel free to email me, follow me on Facebook and on Twitter. So thank you so much for taking the time.
Let's have another round of applause for Dr. Roy. Thank you very much. At least we have hope, and we can always hope. So we now transition to the QA session of this program, where I get to ask Dr. Roy some questions. So Dr. Roy, from your experience, as this crisis has spread across the country, what surprises you the most about the scope of the problem?
Yeah, that's a really great question. You know, I was very surprised. And I'll be honest, I was one of those doctors, those prescribers who was prescribing these medications I hate to use the word like candy, but I inherited a panel of patients that were on all these meds, and I'm like, okay, I guess I need to give it, and I just didn't really understand. I didn't understand addiction, bottom line. I didn't understand that how it worked, how it impacted people, not just physically and medically, but really psychologically. You know, there are similarities to other chronic diseases like diabetes and high blood pressure in the fact that it's chronic and it needs long-term, but I was also surprised by how it's different. And it's different because it impacts a different part of the brain, the most complex machine known to humankind, by the way, the human brain. And it impacts parts of the brain that control emotion and decision-making. You know, in diabetes, it's insulin that affects the pancreas. The pancreas is not impacting really your day-to-day complex decisions. So those are some things that kind of surprised me.
Thank you. Now, as you know, we have many people in the community that suffer from pain, and sometimes they become addicted to their legal medicines. Yeah. How do we help those people that have these legitimate needs?
How do we?
The people that have these legitimate needs.
Yeah, how do we help them?
Yeah.
So, you know, and I touched upon it a little bit, and I could easily spend another hour just devoted to pain management, chronic pain, and pain and addiction. But one key message is that I want to make sure that I'm a little concerned that the pendulum is swinging too far the other way, and that people who have chronic pain are now no longer getting the pain that they need. As I mentioned before, there are people with pain in whom opioids are clinically indicated. They have been using it safely, well, for years or chronically. They are not abusing it, they're not misusing it. It helps their pain. Having said that, there have been also many other people who've been inappropriately prescribed opioids. And that's really, again, going back to what I said earlier, I never, ever got training on pain management when I was in training. We're really changing that now. National organizations like the ASAM, American Society of Addiction Medicine, SAMHSA, CDC, FDA, we're working really hard in terms of changing medical school curricula so we understand that vast majority of pain doesn't even need medications. It's, you know, there's a lot of non-pharmacotherapy. So, you know, learning like yoga, massage, ice, heat, all these things. And then extra strength Tylenol or acetaminophen and ibuprofen, and then scaling it up from there. It's an algorithm, topical treatments. There's so many things, but we just don't spend that time and effort like we need to train healthcare professionals.
Yeah, as an emergency physician, what we've been trying to do now is to try to use as much topical as possible. So we've been using a lot of topical lidocaine in the ER right now to address pain. And the goal is to minimize the amount of opioid we use indiscriminately for this patient population.
Yeah, that's great.
As you said earlier, it's all on the news. It's epidemic. You know, we have to address it. And now we're realizing that our legislative bodies are getting involved in this and trying to regulate how much opioid we prescribe and the duration of the prescription. So what happens is, what do you think the implication of this will be on this patient taking this medication chronically?
What will...
Will they go on and seek some alternative to address their pain?
If what happens, if we stop the opioids?
So basically, in Florida, we just passed a bill that regulates the amount of prescription that's been handed to patients that come with acute pain. But we do have patients that have chronic pains. So by virtue of the legislator being involved in regulating the amount of prescription you give to this patient, will they seek alternatives somewhere else? Yeah,
so this is where it's a fine balance, right? We really do need legislators, policymakers. We need them on our side because we need them to help us really craft policies that are going to help our patients, our clients, our family members who are struggling with addiction. But they need to then be informed by us, by experts, by people who are in the field doing this work. So Yeah, it's easy and this happened in Massachusetts when I was practicing. They said, 3-day supply and then that's it from the ED, or 7 days. But these are arbitrary numbers that are not driven by data. The decisions should be patient by patient. If I see 10 different patients with addiction, say all the 10 of you, each one would have tailored therapy because each of your stories are different. You can't lump everyone in together. And somebody who comes in with acute appendicitis, I'm going to treat that differently from somebody who has cluster headaches, or somebody who banged their knee because they felt. Pain is very individual, and the causes are different, and that's where you can't just have policymakers making those decisions. It has to be driven and guided firmly by data, by evidence, by professionals.
Thank you. By the way, I love the tree you had up there before. And as we all know, sometimes mental health is being masked by this opioid crisis. What should community leaders be doing to address these issues?
Yeah, so glad you brought up mental health. Again, I could have spent easily an hour just devoted to mental health and how that interrelates with addiction. How many people have heard the expression dual diagnosis or co-occurring disorders? Yeah. So many of my patients with addiction also have co-occurring mental illness, and vice versa. It's important to acknowledge both, and it's important also to treat both. So I have patients who've had depression, say for years. The depression is stable. They're on medication, they're getting counseling, therapy, but it's their alcohol use, it's their opioid use. That's really difficult, that's challenging for them. We need to address that. Vice versa, I have patients who've struggled with alcohol or opioids for years, but now it's stable, they're in recovery, they're on medication, they're in recovery, but they're so traumatized by their PTSD, by their work in the military as a veteran. You name the situation, they're severely anxious, they're depressed, whatever. Then we need to address that. And sometimes it's both actively together, and if that's the case, make sure you really partner with the mental health provider, the psychiatrist, the psychologist, get them the care that they need. And that's why I mentioned earlier, integration of primary care, mental health, and addiction really is the optimal environment for our patients to succeed and do well.
Thank you very much. Now the last question I have for you, you've already addressed it on your slide. I mean, I was impressed with that slide with stigma. So the question I have here was, what programs or initiatives have you seen that stands to make the biggest impact on this opioid crisis?
Initiatives? Yeah, I have to say, when you look at the newspapers and the headlines, it can just seem so depressing, right? And overwhelming. But let me tell you something. I would not be here standing before all of you if I did not remain completely hopeful and optimistic. And that's because I'm constantly living and breathing in this world. I'm talking to colleagues that are in the fields doing this work, from all fields, from lawmakers, politicians, senators, mayors, to substance use counselors, social workers, nurses, doctors, and of course, none of this happens without people in recovery. This conversation has to happen with people who are in recovery, also incorporating peer recovery coaches, peer coaches. But I'm also optimistic because I see so many promising projects and initiatives right now. Project Assert in Boston Medical Center, Mass General in Boston has an inpatient consult team that work with the Bridge Clinic and then connecting people to care. In Seattle, LEAD, L-E-A-D, Law Enforcement Assisted Diversion. There's so many programs out there, successful programs that publications like Washington Post, Stat, Vox, New York Times, they're writing about it. And so I read about it because I follow these publications on Twitter, on Facebook. Look up, do hashtags on social media, and you'll find up and coming projects and initiatives. That gives me so much hope. And hearing from patients directly that these medications are helping, the counseling is helping. and really ultimately just taking the time to listen to somebody. Don't judge, listen to their story. I think we'll all be able to relate better to one another because we actually have a lot more in common than we don't.
Thank you very much, Dr. Roy, for your expertise. Can we just give her one more round of applause, please?
Thank you. Thank you so much, really. Thank
well, on behalf of Florida Hospital, we just want to say thank you for, shall I say, weathering the storm, the snow in New York City, and finding a way to get here to speak to us today. Thank you very much.
Thank you so much. Oh, thank you so much. Oh. I don't want to go back tomorrow. I really don't. Thank you. I really appreciate it. Thank you so much.
On that note, we conclude the event for tonight. Thank you very much for coming. Yeah.